Hello everyone, welcome to another episode of podcast where we dive into the eco-guided life support from an Australian perspective. Our guest today is a trailblazer in the field of eco-guided life support, none other than Dr. Allan Whitehead. Allan is a renowned emergency medicine specialist in Australia, a celebrated educator and an innovator who has transformed how we approach critically unwell patients with the use of point-of-care ultrasound. With over 20 years of experience saving lives, he is here to share the insights from cutting-edge technology of ultrasound in terms of eco-guided life support. Allan has trained hundreds of doctors, nurses, medical students, and paramedics over the years in ultrasound. Please join me welcoming the extraordinary Dr. Allan Whitehead.
I am so excited. This is going to be a great opportunity. I can't wait to get started. Amazing.
So Allan, thanks for taking your time and sharing your expertise in this podcast on eco in life support. It's a very interesting topic and there is a lot of controversies, a lot of debate about different aspects of it, and we'll be very glad to have your opinion and thoughts about this topic. And thanks for taking your time. So eco in life support is something that we use in the emergency department and in critical care, or even in the community by the paramedics quite often. Life support algorithm or acute cardiac events, this is a part and parcel of our life. Over the last few years, the ultrasound, especially eco, has revolutionized the way we manage those patients. So what is your thought about this eco in life support, Allan? How do you find this approach and how do you find it different from the other algorithmic aspect of the life support scenarios?
Thanks, Avijit, for the invitation. I think we're going to have a lot of fun in this hour or so. I think we're trying to break a lot of historical convention here. We're not trying to break it because there's still a big place for it, but we're just trying to introduce a new element. And, I do think it has a role, and I'm particularly, we'll talk about it, I'm sure, later in the talk, but I think it has a role particularly around those potentially reversible causes of pseudo-PEA. And it has a role not only in cardiac arrest, but I think it's going to have more of a widespread role in the management of shock patients as well. So I see echo-guided life support as not only for the cardiac arrest patients with a non-shockable rhythm, but also for the shocked patients and what is the cause there, because we're going to get more of those patients. And I think really helping us diagnose the problem faster and therefore making the correct treatment decisions for those particular diagnoses more efficiently, because all of those potential alternative diagnoses, we just can't reliably diagnose them at the bedside. There's no evidence that we can do that in these critically ill patients. There's barely evidence that we can diagnose accurately in stable patients with any chest pain or shortness of breath or syncope. That's really a toss of a coin as well. So I think it helps us answer, really important questions. Things like, is a needle required to fix this problem, or is volume resuscitation required? And if so, how fast should I give it? How much should I give? When will inotropes help fix the problem, or will they not help fix the problem? And if they are required, at what point should I start them? These are particularly getting into more the shocked patients treatment. And I think, it's understandable to call it echo-guided life support because everyone wants to focus on the heart. And the heart is often really sexy to most people who perform point-of-care ultrasound. But it's not really just the heart, because you may be scanning the lungs. We should be scanning the lungs, in my view. That's a fundamental part of doing the assessment in both the non-shockable cardiac arrest patients and also the shocked patients. And also sometimes you need to do not only the heart, the IVC and the lungs, but sometimes the proximal lower limb, sometimes the abdomen, depending on the clinical situation and your earlier POCUS findings. So maybe it shouldn't be called EGLS, maybe it should be called UGLS, but we've got that name already, so we'll stick with it.
Thank you. Excellent answer. So with regards to those, we talk about 4 H and 4 T's. These are the reversible causes. And as you have rightly said, that we can detect a lot of things with the echo or ultrasound rather. We can use the ultrasound to detect hypovolemia, pneumothorax, cardiac tamponade, pulmonary embolism, and also sometimes in case of the MI, which is really good. So that brings up to the next question, that when is in your current practice, when do you find the best time to use the echo during the life support scenarios?
Well, certainly in cardiac arrest, you've really only got that 10-second pulse check window.
Mm-hmm.
And it's probably, to be honest, you haven't got the full 10 seconds, but the subcostal cardiac view is your go-to view, and you should be putting the probe there while the CPR is happening and making sure your machine is correctly set. So you got pretty close to 10 seconds. That's the time to do it. I mean, there is absolutely strong evidence that if you delay the CPR or interrupt the CPR longer than 10 seconds, you do adversely affect the outcome of the patient. So we need to be super conscious of that. And I think ideally having a separate team leader and not trying to do both things yourself, and the team leader is really vigorous around booting you off the chest before you hit the 10 seconds is really important. So that's the time to do it. Sometimes there's a very, very quick opportunity to do it right at the start, but that's the best time to do it and the appropriate time to do it.
So I think the bottom line here is the ultrasound is not a priority here. The priority is the chest compression and shock if necessary, and some other drugs like adrenaline. And if we get some time during the assessment of the rhythm, then we can do the ultrasound to find out what is going on.
Yep. And practice, we'll come to this later, I'm sure, when we talk about training, but really being practiced so that you are efficient, and also having those sufficient experience and training that also allows you to be efficient. I think you and I would agree that the person who does the ultrasound should be the best ultrasound practitioner in the practice available to you at the time. I think often I would agree with a lot of other people that a well-trained nurse can really be the team leader. Yeah. But unfortunately, at this point in time, I would like to see it change in the future. They're not usually someone that can do the ultrasound. So I would rather give them the team leader role, potentially in my small department, while I'm concentrating more on the ultrasound role and the acquisition and the interpretation, which comes after the 10 seconds, which is really important as well. Everywhere that I've learned this and I've been teaching this, we're really focusing on getting the best images you can in the 10 seconds, and then making sure you record and then interpreting separately away from the patient. Because if you try to do both at the same time, you inevitably stuff it up or perform inferiorly or make a mistake. So just making sure that you're concentrating on the best acquisition, less than 10 seconds, and having a protocolized approach, which is the EGLS algorithm protocol is that's the only one really personally I'm aware of, and I think it's a really sound protocol. So practicing that and going to the lungs first, I think, is really important.
Yes, I think I completely agree with you. That 10-second time that is so important. It's like the intubation. If you want to intubate this patient, the most experienced clinician should do the airway and do the intubation, because you will have just 10 seconds to do the intubation. Similarly, the echo, that is the most experienced clinician should do the echo, while the team leader, that can be done by someone else. Even a senior registrar or a nurse with appropriate training can do that. So what are the benefits? We have already talked about some benefits. What in your opinion, what are the most crucial benefits that you find in the application of echo in these type of scenarios?
I think in the critically ill patients, both the cardiac arrest and the shock patients, because you're really looking for the same things. It's just how long you've got to look a lot of the time. I think for me, I really like the idea that it gives me increased confidence as a clinician in diagnosing the underlying cause of a pseudo PEA arrest. So that non-shockable rhythm, I'm trying to work out firstly whether it's a true PEA, which we may talk about, or we'll talk about in a second. I think I'll go on to that. And versus the pseudo PEA, the pseudo PEA being where there's mechanical cardiac activity but no output. And that's those potentially reversible causes that you were just talking about, Abhijit, the 5 H's or 5 T's, or the 4 H's and the 4 T's. And it's amazing how POCUS can help you with half of those at the bedside. And then once you add in your blood gas and your vital signs and your ECG, then you can answer all the others. So it's an amazing tool. And then, then I think I really then have a really good confidence and feel as to whether the patient has a potential pneumothorax. I can at least rule it out, and I may not be able to 100% rule it in, which I can't, but when a patient is that sick that they're either arrested or they're peri-arrest or shocked, even if I just see an absence of lung sliding, which doesn't necessarily mean that it has to be a pneumothorax, it could be a big bolus or something like that, a big trap. But the patient's that sick, you're really justified in sticking a needle in. But I don't really favor this idea of sticking needles in blindly in the chest without any objective evidence to back you up, because I just doubt that there's no evidence that the clinical findings are reliably detected. And then you've got those other ones as well, like tamponade. We don't want to be blindly sticking needles into where we think the heart is when we don't even know that they've got a large pericardial effusion. Hypovolemia, cardiogenic shock, the treatments are so different. In one, you want to give volume, and the other one, if you give volume, you're going to make the outcome worse. PE the same. If you give volume, you're potentially making the patient worse. So it's really important to get the right diagnosis. You get the right diagnosis, you get the right treatment. Getting all that happening faster is got to be beneficial to the patient, I think. And then you've got the counter to that, the sort of sad scenario where you've got the true PEA situation where there's no mechanical activity happening, no squeeze of the heart, even though there's electrical activity happening on the monitor. And that is still a useful thing for me as the clinician looking or contributing to looking after the patient, because I know then the prognosis is very, very poor. Now, there's special circumstances, as we know, where that's an exception, like a toxicological cause such as beta blockers or calcium channel blockers or hypothermia. Now, there's special circumstances where the heart's potentially should recover and then the brain hopefully will recover. But in every other patient, it's a really, really poor prognosis. So it's certainly one of my data points. I'm not sure about you, Abhijit, but it's certainly one of my data points that I would take into account when deciding how long to continue the resuscitation. What do you think?
Yeah, I think it's a complicated topic, and there is not much research in this topic either. The ultrasound has been used just over the last few years, and the research that we have, it does not give a very strong evidence that actually gives us all the information that are required. Most of the information that we have so far are anecdotal and low quality research that shows that yes, it can be useful if we can apply it in the clinical context, and also it needs to be done by the most experienced clinicians with enough knowledge and expertise. So we cannot get a definitive diagnosis whether it is a PEA or pseudo PEA or something else going on, but some important information may be achievable with this echo. and some of them can be helpful in formulating a plan for the management of those type of patients.
Yeah, I suppose that the area that there's a couple of things. One is there's a couple of papers that in the shocked patients have indicated that if you employ point of care ultrasound in those patients, you can make the diagnosis faster by 15 to 20 minutes. And therefore, you would hope that therefore the correct treatment is starting 15 to 20 minutes faster. So I think that's a positive. It's hard to prove final outcomes because there's so many confounding factors in an ED department stay for a patient and an inpatient stay. So I personally think you can't really ask ultrasound to do more than give you the correct diagnosis and hopefully therefore starting the correct treatment as early as possible. That's really, I think, a realistic aim for ultrasound, and it's really all it should be expected to do. And then when I look at the international guidelines, the ACLS or international guidelines by ILCOR and the Australian Resuscitation Council guidelines, their most recent iteration about incorporating point of care ultrasound into this sort of PEA question is at some point, if there's clinical suspicion that the patient isn't responding, then put the ultrasound on. But my concern is the clinical suspicion isn't reliable anyway. The evidence shows that there's no reliability to someone's clinical suspicion. When they may be suspicious, there may be no problem, and when they're not suspicious, there may be a problem. And then the other thing is the delay before they get suspicious. That's going to mean there's quite a lot of time potentially before someone decides that, oh, it's time to put the probe on because it's not going the way we thought. And I think then you've lost the chance.
It is like almost like an elephant in the room. If you do the ultrasound beforehand, then you can identify that early rather than just waiting for that clinical suspicion, isn't it?
Yeah, unfortunately, fluids and inotropes will only get you so far, and if it's a tension pneumothorax or a tamponade, that's not gonna help.
No. So over the last few years, you have got a lot of experience in this field. So do you like to share some of your examples or the experiences that you had?
Did you want to show the cases, or are they going to come up slightly later?
Yeah, they are coming up.
Okay. So
a quick summary for the audience that usually for the echo in life support, we use the subcostal view. But if possible, we can do the parasternal long axis view. Mind that this is the area where the chest compression is going. And same thing is true for apical four-chamber view. Very difficult to do in cardiac arrest. So the easiest view probably is the subcostal view.
Yeah, and you often find the patients that are arrested, they're often smokers. So they're COPD, they're hyperinflated, and often you get a brilliant subcostal cardiac view, don't you?
Yes.
And on top of that, if you really needed to, you could throw in the off-textbook subcostal short axis view, which isn't a bad little view. It gives you, some, particularly if you're starting to think about pulmonary embolism, the ability to see whether there's a D sign from the subcostal area is quite a useful trick as well.
Yeah. So, Allan, thanks for sharing your cases. So this will be your first case here.
Oh, thanks, Ivajit. So I'm just presenting a couple of cases. The first one is just a few slides, and the second one, there'll be a few more slides. These are both cases that I was personally involved in. The first lady, elderly, collapsed at the triage desk. She had one of those, she really got one sentence out of her presenting complaint of pain and then collapsed. And it was a pain pretty much everywhere. It was in her back, it was in her shoulder and, shoulder blades and epigastric and into the lower limb. And whenever I get one of these pains that's going sort of everywhere, and particularly when it's starting to go above and below the diaphragm and involving limbs, dissection is always in my differential diagnosis. And then we carried her into the resus cubicle and basically put the probe on pretty much straight away. And this is what I saw in the subcostal four-chamber view. And the thing that sort of struck the eye is that the anterior pericardium is quite bright. And then the reason that is there's some sort of extra fluid sitting on top of the heart. And what you've got sitting on the top of the heart, which Abhijit is pointing out, is you've got a combination of some runny fluid and some thick sort of either clot, probably blood clot scenario rather than pus, but it's sort of light grey, almost white. And it's certainly a phenomenon that I've seen before and other people have described. When you have super fresh blood, it's literally only been there for a few minutes or seconds, it seems to be almost white. I don't know if they know the underlying mechanism for that. Do you know, Abhijit? I've always thought maybe it's because it's still quite oxygenated and that's got something to do with it. But have you seen that scenario before where when you have really fresh blood, it looks sort of very light grey, almost white, blood clot?
No, I did not. So usually
Yeah.
I see the clot that I have seen, that is whole of the pericardium. And my understanding is that this is the dependent part, isn't it? The diaphragm will be here. And so due to gravity, the blood will collect mostly in the dependent part. If there is a clot, that should collect towards the diaphragm rather than to the heart. And I don't have an explanation why it is on the surface of the pericardium rather than on the surface of the diaphragm.
Yeah. So I mean, it goes with the history because we sort of got the impression that this pain was fairly acute onset. And so when I saw that, I thought, oh, this is hemopericardium in this setting, and very fresh because it looked almost white. And then going to the other views, which also the subcostal four chamber was hinting at, but these probably tell you even more with that parasternal long view. You can see the mitral valve is there's a little bit of motion in the mitral valve, but it's barely moving. And the myocardium is really not moving at all. Just be careful. Don't interpret mitral valve or aortic valve movement as necessarily cardiac activity, because, you know, if we're putting in some fluids, you're going to get some motion of the valves just from the fluids circulating through the left ventricle. Look, it's more important to look at the muscle itself. The muscle is not doing anything. So this is a really fresh hemopericardium, most likely from one of two diagnoses, as we know, in this setting of non-trauma. It's going to be either a type A aortic dissection with hemopericardium or a myocardial rupture. And I slid the probe just a little bit down towards the apex that Abhijit was just showing then, and you could see it outlining the apex very nicely. The aortic root in that slide on the left actually looked fairly normal size. We used something called the rule of three. So the left atrium and the aortic root and the right ventricular outflow tract look roughly the same size. And when you look at the scale on the side, it's really only like, you know, certainly well under 3 centimeters. And you really only start to be worried when it's sort of over 4 centimeters. So look, it could have been either, but when I'm in a small ED in this setting, there's certainly no cardiothoracics on site. And we're certainly some distance from Melbourne, over an hour, then this actually finding allowed us to basically call it there and then, and not do a round of sort of 20 to 25 minutes of ACLS and CPR before we stopped, because it's really a futile exercise in this setting. And the true PEA situation which we have here, there's no heart motion. That also is indicative of a likely poor prognosis. And when you've got both those things together in this patient, it was a very useful tool. It didn't actually sort of allow us to treat anything differently, but what it did was allow us to cease treatment. And I don't care where you are, whether you're in a big ED with lots of staff or not, you're always under the pump, especially these days with COVID and post-COVID. And to be able to use your staff efficiently and with most benefit to the patient is really important. So in a small ED where this was, I would have used up all of my medical and nursing resources just on one patient pretty much for the next 20 to 25 minutes. And therefore, that's potentially adversely affecting the outcomes of the other patients. So it's I think that's where in this case, I would also argue it's a useful tool.
It's a very interesting case, especially it shows that how the echo can affect your decision-making depending on your department, your resources available, and your what the facilities you have, whether you need to retrieve this patient or treat the patient then and there. I mean, if the same patient was in central part of the Melbourne, how would you have done differently, Alan?
I still think that the outcome is very, very poor, even if she collapsed at a cardiothoracic center. What I would say is I'm aware of another case similar to this who arrested in a metropolitan ED in Melbourne, but the key difference was there was still cardiac activity. So it was a pseudo PEA rather than a true PEA situation. And the emergency physician, who I know quite well, actually aspirated not a large amount of blood, maybe 50 mils or something like that. This was actually at the point when CPR was about to be ceased until he put the probe on. And then the patient regained output, was successfully transferred to a tertiary cardiothoracic center and survived ICU. So, but it's clear that someone whose heart's still squeezing is got to have a better outcome than someone whose heart isn't squeezing. And there were certainly people there was a large multi-center study you'd probably be aware of, Avigit. It was around 750 to 800 patients in the US. And there were 2 people who survived to hospital discharge from a true PEA situation. But, people made it into hospital, but extremely small number, only 2 out of 800 made it out of hospital. So, that's the whole thing. Are they ever going to make it out of hospital?
But these 2 patients who actually got benefited, that is 100% for them, isn't it?
Well, the only problem is we don't know what their cognitive status was.
That's true. That's true. So long-term prognosis is completely different chapter. And so this is your second patient, Alan?
Yeah, so this one, a little bit longer in this one. So this one was in the age of COVID. And so you'll notice reference to hot ED. So there was 2 separate EDs, as quite a few EDs did, certainly in the initial phases. And I actually happened to be stationed in the cold ED, and in a small ED where I work, there's 1 consultant on at a time. I should say that I'm not currently working on either of the 2 cases where these EDs happened. But again, I was there. This is a different one to the first case, different place, but similar small place, no HDU. And so this patient was in the the hot ED, and had been labeled as cold sepsis, and was like reasonably stable for several hours, had a sort of a borderline tachycardia, and maybe he'd been a little bit short of breath for a few days. And they looked at the X-ray and saw a definite sort of evidence of a cardiomegaly, quite impressive. So there was some query that the patient may have a pericardial effusion, or maybe they've got endocarditis. And this patient had a sudden deterioration after being in the hot ED for several hours. And by the time I ran there from the cold ED, which was a few minutes of running, then he'd already arrested and CPR was in progress. He had some various rhythms from sort of asystole to pulseless VT and AFib apparently before I got there, and he was intubated. And it was a very sudden deterioration. But given that there was a question of pericardial effusion already based on what I'd heard from the chest X-ray, then I just thought I'm not going to start with the EGLE system of the pneumothorax assessment, because my money is that there's a tamponade going on here. So I put the probe on. So we'll show the next picture. And you'll notice a couple of things. One is this was with a handheld probe, and we're going to talk about this a little bit later. But, almost running at full pace with a handheld probe is a lot easier than running at full pace with a cart or a laptop-sized machine. And especially when I'm maybe carrying it from another department. And so I went to the subcostal view, as Avijit said, your go-to view when CPR is happening. And I must have been a little bit excited or breathless or something, or dizzy from the run, because unfortunately I must have pressed it twice on my iPhone. So this is still a still picture, like a 1 second still picture. But I managed to extract it. And as Evergett's pointing to, we've got the liver at the top of the screen. And we've got this space of about a couple of, probably about 3 to 4 centimeters between the lower border of the liver and the anterior pericardium. And then we can see heart from about 11 centimeters of depth all the way to the bottom of the screen. So obviously in a real clip, you're seeing this a little bit better, but there's a good going, 3 to 4 centimeter pericardial effusion here. And then I went on to the next view, and you'll see it coming in here, parasternal long. And here we go there. And you can see, the heart's literally surrounded in this fluid. There's still a little bit of mechanical activity happening of the heart there, a little bit. The aortic root doesn't look big. Yeah, so I'm going, this is this patient's arrested. This is tamponade. If this is a shocked patient or an arrested patient, PEA or pseudo PEA with this large pericardial effusion, it's tamponade until proven otherwise. So basically, as soon as I got these two views, I know I've got to stick a needle in. So I didn't actually have time to guide a needle in. This patient's already arrested. They're having CPR done. I didn't even have time to X marks the spot. I just had to sort of eyeball it. So I went to the apical view because normally that's not a bad window to get the deepest pocket. And you can see, as Evergett's pointing out, rolling around the apex there, there's not a bad pocket that's going down, maybe sort of to about 6 or 7 centimeters. You could safely get the needle in without praying the heart. And actually what happened is I just eyeballed it and put the needle in, and I missed the first time. And so then I put it in again, which I think is probably referring to the next slide. I reset. So in that one, I reset my position. I missed. And I reset and I sucked. And then when I reset my position, I got 200 mils of frank blood out pretty easily. And, you could say, oh, how do you know that you weren't in the, the right ventricle or the left ventricle or the aorta, But actually when you'll see with these subsequent views, the amount of fluid around the heart is clearly visibly reduced there in the parasternal long compared to before. So I must have got, the blood out of the right spot. Otherwise it wouldn't have shrunk. And as I said, the aortic root looked pretty good there. We're getting some mechanical activity, and certainly the output definitely improved after this. And we actually did get him, we did manage to wean his inotropes at some stage. Unfortunately, after that, over the course of the next hour, he sort of deteriorated again. This isn't my best. That was my best attempt at a parasternal short axis view, I think. No, or was it a subcostal? I think it was a. Can you go back to the previous one? Sorry, Evergett, if you're able to do that. Yeah, that was the subcostal 4-chamber view. It looked a bit rounded, so that's why it confused me for a second. That was again showing that definitely the amount of blood around the heart has gone down compared to what you saw in that anterior pericardial space. And then I swung into a parasternal long. I just kept the probe on and just sort of slid up the chest to the parasternal long to assess the aortic root. And I also looked in the next slide, Evergett, if you like. I also looked at the proximal abdominal aorta to see if I could see a flap in the transverse plane. I'm just trying to look for any potential causes of this hemopericardium, because we know it wasn't just fluid, it was actually frank blood. And so, I'm thinking again, similar to the previous case, was it a type A aortic dissection? Was it a myocardial rupture? He actually had an ECG that didn't show any ischemic changes before the arrest, but actually had pulsus alternans, which was missed. And his troponin was normal. So it's pretty unlikely it was a myocardial rupture. And there's nothing in the aorta, in either the aortic root or the proximal abdominal aorta, it's really suggesting that's likely to be the source. I mean, it's not perfect, but the probability is low given those things look fine. So in retrospect, we're thinking maybe it was just a very malignant pericardial effusion and very, very bloody. Unfortunately, we never got him to the CT scanner because he deteriorated before we could do that. And I think there was another slide that I want to show you, which relates to airway. I think I went into the long aorta here, and you can see that's another view of subcostal and IVC. We can skip on to the next slide if you like. Yeah, the IVC was pretty normal size, although he was intubated, so you've got to use different parameters there. But the thing is, so I stuck the needle in first because, you know, that was really the prime. It wasn't really an airway issue straight away. In that, you know, I had to address the fact that he had arrested and it was tamponade. So the first treatment really, in my mind, was getting rid of the blood, and then because that it was compromising his output. And then once we got the output better, I'm thinking, you know, everything's starting to look like it's going okay. We got him on some inotropes. He's got a reasonable blood pressure, and I'm looking at the end-tidal CO2, and I'm going, you know, he's got a reasonable output here, a reasonable blood pressure, and this end-tidal CO2 is not picking up. Now, when he's in tamponade with no flow going from the right side of the heart to the left side of the heart, you expect the end-tidal CO2 to be down. But now that he's got good flow happening, good blood pressure, you sort of expect that would pick up, and it never picked up. And I'm looking and I'm going, I don't like that. So then I thought, what will I do? So I put the probe on, transverse probe, and put it, I just grabbed my phone. I don't know, you might be able to see a picture of me, but I just put it on the trachea, transversely, probe marker to the right as per normal general ultrasound convention. And Avijit will point out that the trachea is on the left side of the screen as you look at it, where on the probe marker side, the probe marker side, Avijit, yeah. So that's the trachea, the bigger one, casting the shadow, pardon me, because it's got air in it, so it will cause a shadow. But you should only see one shadow if the tube is in the trachea. The concerning thing here is there's two shadows. So this means that we've actually got air in the esophagus, and it's being splintered open by the endotracheal tube. Normally it would be collapsed unless there's a nasogastric in there, and you shouldn't get any air shadowing off the esophagus, which is the one on the patient's left-hand side or the right side of the screen as we look at it. And you can actually see the air flicking right in the surface of it, the sort of anterior surface of the esophagus. There's a little bit of air flickering as we ventilate the patient. So that's a esophageal intubation proven with ultrasound. So we took that out and reintubated the patient. Now, if you were doing a nasogastric, that's what you want to see. You want to see two shadows, but you know, you don't want to see that with an endotracheal intubation. Now, this trick works on 99 out of 100 patients, but in 1 in 100, the esophagus is behind the trachea. So you can't use this trick. You could use lung sliding. Your lung sliding is, you know, perfectly valid way of making sure that you're ventilating the lungs. Have you ever used this trick, Avijit?
What about if you use the ultrasound probe on the side of the neck? Then you can, so 99 of 100 people, you can still see the esophagus, can't you?
I haven't tried that one, but yeah, it might be worthwhile having a try. I mean, again, as I said, you know, if you're not confident doing this, just at least if you know how to do an E-fast and looking for lung sliding, at least if you see one lung slide, you know that you're in the airway. You might have pushed it down one lung too far, but at least you're in the airway.
That's an excellent case. So there are so many things to learn here. Obviously, it was a very time-critical, life-threatening condition, and you have used this handheld device in which the person has got some reversible cause, which is cardiac tamponade. Then you have detected that this person has got a wrong intubation. And I don't know how long this person was intubated to the esophagus. How long for?
I'd be estimating, well, in excess of 10 minutes.
Wow. And he was still surviving at that time.
Yeah, I mean, I suppose, you know, the initial focus was, first it was a few minutes before I arrived, but then the initial focus was, you know, aspirating the blood. And
yes.
Yeah, and that, you know, realistically, that's still a few minutes of your time, because you've got to I sucked up 200 mils. So that takes a bit of time in itself, right? Because you're changing syringes multiple times.
Yeah.
Yeah, so that was a few minutes, and then it's like, okay, and the blood pressure's coming up, and what else do we need to address? And getting those other views, you know, I had to try to get other cardiac views as well to try and answer, like whether it was a clear dissection. And then it's like, okay, I think I've done everything else I need to do with the ultrasound and pay attention to the rest of the patient. And that's when, you know, that wasn't sitting right, because we've addressed that problem of flow around the circulation, and the end-tidal CO2 was just not coming up. Yeah, I mean, but I think that's a critical message for young players, and I would say I've had this discussion with anesthetic doctors as well, is that when you've got a obstructive cardiac arrest, whether that's tamponade or massive PE or tension pneumothorax, you need to be aware that you can't use your usual go-to of end-tidal CO2. That's going to be low, and you have to have a backup plan. And therefore, I try to teach them to have some ultrasound backup plan in that situation.
Excellent case there. Thank you for sharing that, Alan. And this is the same patient, I believe.
Same patient, and this is when things were going well after we've, aspirated, we've intubated the patient, and things are looking good. And we can move on to the next slide if you want.
Yeah.
And I think, and then things deteriorated after that. And the point of this slide was, I just wanted to demonstrate that I had the probe on subcostally while they were doing CPR, and it actually was surprisingly good in demonstrating how effective the CPR was.
Yes.
You can see you're getting some really nice compression. Not only of the RV, but even the LV. I think that's pretty impressive. Now, you probably read the same literature, Abhijit, that when they're using transesophageal echo in the States, and the advantage is it can stay in, and they're visualizing the CPR with the transesophageal echo, that they can get a really good sense of how good the CPR is. But, even sometimes, it's not a bad idea even to put the probe on, as long as you don't get in the way of the person doing the CPR. It's not a bad idea to put the probe on at some time early on when they're doing the CPR, because, it is really reassuring to see that. Now, you're not always going to get as good a picture of that, but, it did make me feel good when I saw that the CPR was as effective as I was hoping it would be.
Excellent. Thank you for sharing that. We don't see this often.
And that's at the point where we're in a true PEA situation, so things are looking pretty grim. And shortly after that, we really called it. Yeah.
75 minutes.
And we never got an ultimate diagnosis because we really couldn't move him to the CT scanner. But for me, this is a coroner's case. There's nothing sort of potentially sinister, or anything that potentially raises any flags that it's purely anything apart from some medical cause.
Absolutely. This is one of my cases. It was not a cardiac arrest, but it was a peri-arrest scenario. So this person came with upper abdominal pain, and we are doing the fast scan, and we found this during the cardiac view. And I did the comprehensive echo in this patient. And this may be a little demonstration for the young learners that what the cardiac tamponade looks like. So that's the liver here, the diaphragm is here, then this big black pool of something, liquid, which is in the pericardial cavity. And this is the right atrium, right ventricle, and left atrium. And as it is demonstrated very beautifully here, that the right atrium and right ventricle both are collapsed because the pressure here in the pericardial cavity is greater than in the right ventricle and right atrium. So this is the sonographic picture, how the cardiac tamponade looks like. The reason we would like to look at this type of clips is for our training purposes, so that in this rush in cardiac arrest scenario, we will try to look for this type of thing. And if we don't see this in non-cardiac arrest patient, it's sometimes difficult to pick up in the cardiac arrest because we do not know exactly where to put the probe and what to look for.
Yeah, I mean, I scan more patients that are stable than are unstable shock or cardiac arrest. And I think that's a really good way when you're also learning to practice on the stable patients. You've got so many chest pain, shortness of breath, syncope that you can practice on in short stays, a great place to practice. And I guarantee you'll start picking up pericardial effusions that'll be close to this size, certainly moderate ones, and I've picked up quite a few large ones. And some of those had already been sent home once before, like 5 days ago or a week ago. And so you will see them, and that's a great place to start to develop your confidence in picking up the positives. But the good thing about large pericardial effusions is generally they make the heart very easy to visualize, don't they, Avijit? And certainly when you're doing any of the precordial views, they push the lung out of the way when they're this big.
Yeah, so this is a very interesting case. So this person needed pericardiocentesis, and a week later he came again with chest pain, and I did the echo again, and he did not have any of this, and I really struggled to see the heart. So with the pericardial effusion, the heart looks very well and very clear.
Was he compromised at the time that you did the pericardiocentesis?
He did not, but just after I finished the ultrasound, he became tachycardic and hypotensive, and that is when he was taken to cath lab straight away.
And which approach did you do, Avijit, for the needle?
I'm sorry, that was done by the cardiology. So
okay.
It was a big.
Have you done any yourself, Avijit?
I did couple, yes, in the rural hospitals, and I did subcostal.
Which approach? Subcostal. Okay.
I found that easier. I still feel a bit nervous about putting the needle in the apex because of the lungs, and subcostal is relatively easy and relatively safe. Even with ultrasound, it becomes so easy.
I suppose the good thing is if you're doing it in a precordial, like apical or parasternal, if you can see the heart, then the lung by definition can't be there. I've heard of, I haven't done it myself, but I've heard of a couple of people around town in Melbourne who've done the a parasternal approach as well, which, you know, again, I'm sure like most things in medicine, there's more than one way to skin a cat.
Yeah, absolutely, yes. So I've got few cases, and this patient on the left-hand side, it was again, peri-arrest scenario, shocked patient. And when I did the ultrasound or echo, we found that the left ventricle, this is the parasternal long axis view, and the left ventricle, it's almost like kissing walls, and it is hyperdynamic ventricle. And after giving some fluid, he responded very well and did not turn to the cardiac arrest. Unfortunately, that is not true for this person on the right-hand side that I am pointing to. Elderly man in his late 70s with multiple comorbidities. He did not have any advanced care life support, advanced care directive. So when he had collapsed in the department, we had to start the CPR, and I did the subcostal view, and during the pulse check, this is what it looks like. And as can be easily seen, that first of all, there is not much movement of the ventricles, and there is probably some clot in the ventricle as well. Now, Alan, you use the term PEA and pseudo-PEA.
Yeah.
This person did not have any pulse, and I don't know what you will call it. Will you call it a pseudo-PEA?
I mean, it can be a little bit difficult to draw that line about at what point do you think they actually got mechanical activity. I mean, to me, I would say that that's true PEA. I don't see any really convincing mechanical activity. The other thing is, I know there still looks like there's a bit of a D sign there as well, with some increased pressure in the right side of the heart pushing down on the left side of the heart. So, I mean, that also fits with, you know, your presumptive diagnosis of PE. You know, if there was convincing mechanical activity here and the patient's compromised or arrested, I'm sure you're starting to go through that process of thrombolysis. And if you see convincing clot in the right side of the heart, whether it's in the ventricle or the atria, that's probably a more easy decision. The difficulty is when you're relying on just seeing signs of right-sided heart strain, because there are other things, as we know, like COPD and cor pulmonale that can cause those features. So, but it's unfortunately it's a rarer circumstance when you're fortunate enough to see clot in the right side of the heart. But I actually do think about the rush protocol in that situation and how they would go down to the lower limbs and at least do a quick proximal DVT scan in a couple of spots on each leg to help my decision making. So again, I think this is the thing where we just got to be careful that we don't, even though it fits nicely and it's the way it's labeled EGLS, remember, it's not just echo. You can put the ultrasound on, the proximal DVT, and that will give you some information if you're thinking about PE and trying to work out the chances that it is a PE or isn't a PE, and therefore thrombolized or not thrombolized. Or maybe, as Avijit had that first case there on the left, where the walls are almost kissing, maybe the IVC is also thin and almost kissing, and you're thinking this is an under-volume problem. Well, if they're old, I'd probably go to the abdominal aorta, Avijit, and look for AAA. And if they were young, I'd probably do a fast and see if there's any free fluid in the peritoneal cavity, because it could be premenopausal lady with a ruptured ectopic. It could be someone with a spontaneous splenic rupture or a hemorrhagic ovarian cyst. There are all these things that do happen rarely. So that's sort of my thinking.
Yeah, thank you. So I for this particular patient with cardiac arrest, I thought it is a pulseless electrical activity because there is not much effective contraction at all. And we went through the pulseless electrical activity pathway in that patient. And after discussion with the family, we called off quite quickly. So you were talking about D sign for those who are not familiar with it. So this is the parasternal short axis view. And this is the right ventricle here, left ventricle here. And this is the interventricular septum, which should be circular. The left ventricle should be circular. But here the left ventricle is like a D because the pressure here in the right ventricle is greater than in the left ventricle. And this person has got, again, a peri-arrest scenario, recent knee replacement, coming with shortness of breath, almost like collapsed on the floor. When I did the echo, it showed like this, and we thrombolized this patient, and she did very well. She was discharged within 3 days from the ICU.
Did you repeat the echo after the thrombolysis?
I did this, yes.
And could you see the ventricle come down in size?
That's right, yes. So the
that's
right
really
ventricle was circular, yeah. And this is another cardiac tamponade that we discussed. Excellent. Thank you, Allan, for sharing that. So if we summarize everything, echo is a very important part of the advanced life support. How we use it and when we use it can be controversial, but at the end of the day, we can get a lot of information that actually can help the patient. The most experienced clinician should perform the echo during the advanced life support. And the way we can make a person most experienced is by training. The training can be done by attending courses, doing different programs from university. But at the end of the day, this is the personal interest and enthusiasm that can help one well-trained. We have got a lot of materials as a reference, and as Allan has rightly said, there was this article for the eco-guided life support, which is this article by Langtot and Valois. This is a free article, so anybody can download it and read it. This has got the algorithmic aspect of use of echo in life support cases. Thank you, everyone. And thank you, Allan, for taking your time. It was great, very informative and very educational. I learned a lot of things from you, as usual. And I hope that we can see you again in another episode of podcast. Thank you very much.
Thanks, Avijit. You can see I get very passionate when I talk about POCUS like you. And this is my first ever podcast, so I really appreciate the opportunity. For an old person like me to actually do a podcast is a thrill.
No problem at all.